Hi guys. Today we're going to talk about chapter 46, which is the role of ultrasound in evaluating female infertility. And the interesting thing about this chapter is you've gone over a lot of this stuff when it's come to pathology of the uterus, ovaries, and adnexus. So a lot of it will be just a really good review for you before we go on to obstetrics. So evaluating the cervix, that's going to be our first thing that we'll look at when we're evaluating for infertility. And the role of the cervix in fertility is to provide a non-hostile environment to harbor sperm. So the cervix does this with glands that secrete mucus and crypts that hold sperm. And ultrasound is used to evaluate cervical length during pregnancy to assess for cervical incompetence. When we talk about cervical incompetence, what that means, and we'll go over this later, especially in OB2, that sometimes the cervix decides to open earlier than it should and cannot hold the pressure of the baby in the amniotic sac. So it dilates, and a mom could have preterm labor that way. In a non-gravid, which means non-pregnant, uterus, or has never had a baby, the length of any opening in the cervix is difficult to assess, but hysterosalpinography can be used to evaluate internal os diameter. To be honest, we don't do much with the cervix when we're evaluating for infertility because this slide says, it's kind of difficult to evaluate. We do evaluate the uterus. It's a huge thing. So our two main objectives are to assess the structural anatomy. So is there a congenital anomaly, like the ones we've talked about, bicornuate, septate, something that could cause the embryo not to implant, and also to assess the endometrium. This is an image of a bicornuate uterus. Now, if you guys can remember back to when we talked about these congenital anomalies, with a bicornuate uterus, usually these patients don't have trouble getting pregnant. When it comes to a bicornuate uterus, most of the time the patients do great, but there could be a chance of preterm labor later on in the pregnancy, but I don't think they really do struggle getting pregnant. So when you're evaluating the uterus, there's a couple of questions that you'll want to ask yourself. Is the uterus uniform in echogenicity? Now, what could it mean if it wasn't uniform in echogenicity? That could be adenomyosis, that could be a fibroid, there could be some kind of mass. And that leads us to our next question. Are there masses suggestive of fibroids that may impede implantation of the fertilized egg? Now, if you guys can remember, ask yourselves what kind of fibroid would cause the most trouble with the implantation of fertilized egg. And if you said submucosal, you are correct, because the submucosal fibroids, they push on the endometrium and can cause just impede implantation, basically. When assessing the endometrium, evaluate the thickness, echogenicity characteristics, include evaluation for intracavitary lesions. Now, what would be an intracavitary lesion? Well, you could have a polyp, and that's a huge thing. That's one of the things that could definitely cause infertility. You could also have a septum. That's another thing that could cause infertility. So these are all things that you need to be thinking about when you're evaluating the uterus for infertility. This is an image of a uterus with multiple fibroids. Now, this happens more than you would think, that you get in there, you do a transvaginal, and you see just these masses. And look, there's 3 of them right there. This would definitely If your uterus is filled with this many fibroids and you're not getting pregnant, it's probably because of the fibroids, because this is a lot of fibroids. So what they can do is a myomectomy, where they go and they can take the fibroids out if the patient is wanting to get pregnant. Okay, so the congenital uterine anomalies are the result of a Müllerian duct development, fusion, reabsorption, and anomalies are associated with renal anomalies, except for arcuate and septate. Okay, guys, if you remember, one of the things, if let's say a patient has uterine agenesis and just doesn't have a uterus, they have a higher chance of having renal agenesis, at least one. They wouldn't be alive if both kidneys weren't there, but if one kidney not being there, because the kidneys, the renal system develops with the uterine system in the first trimester. So they have, they correlate together and have a higher chance of potentially having a renal anomaly with a uterine anomaly. Here's a couple of our uterine anomalies here. A septate uterus. And, you can see this is a transverse ultrasound of the uterus, and you can see two parts of the endometrium, but it's not connected, and there's just hypoechoic area in between. But it's just like, is that a uterine didelphys? Is that a bicornuate uterus that we see? Just really hard to assess that way. So that's where this awesome 3D image comes into play. So this is a coronal view. If you had laid the uterus out flat, cut it in half, and you're looking at it, and you can see that there is a septum that has totally cut through the endometrium, because usually the top of the endometrium will be right here. Of course, this would cause implantation problems, don't you think? But isn't this the best way to evaluate this? That's why it's so great to have a 3D transvaginal probe, and I hope more places start to get them, especially when they're dealing with this kind of stuff. Okay, so evaluating the endometrium. It can be measured throughout the menstrual cycle to look for appropriate changes. Now, if you remember, after menstruation, it's pretty thin, and then as you go through the different stages, like the proliferative phase and the secretory phase, it should get up to about 15 millimeters. If it's greater than 15 millimeters, it's considered too thick. The thickness encompasses the thickness of both the anterior and posterior endometrial layers and the sagittal plane. In the first half of the menstrual cycle, the mucosa begins to proliferate because of the increasing estrogen levels. And so the estrogen levels are what help it to get thick. 3-line sign, do you guys remember this? This is going to be on your final, and you need to just know this being a sonographer. So this is a proliferative phase. So this is late proliferative phase. So I would say this is about day 9 to day 14. After ovulation, progesterone is secreted by the corpus luteum. So secretion of the progesterone begins the secretory phase of the endometrial cycle. During this secretory phase, the endometrium becomes even more thick and very echogenic, and you lose the triple line sign, if you remember. And this is what you get. 1.46, so that's great. This patient is probably in late secretory phase, and it's just very echogenic, no 3-line sign. So when you're evaluating the endometrium for infertility, you want at least a thickness of at least 6 millimeters to be the central threshold for achieving pregnancy. Now, ideally around day 14, you want it about 1 centimeter. So you want it at 10 millimeters. If there's not enough progesterone in the luteal phase, the endometrial lining may be thinner than expected on ultrasound. And this is called a luteal phase defect. It's associated with infertility and early pregnancy loss because the endometrium is not thick enough for implantation. So the endometrial appearance is important for planning for infertility treatment with embryo transfer. Now, if a patient does have a luteal phase defect and they're going through infertility treatments, they have a pretty high chance of being put on progesterone to help thicken that endometrium and help support a pregnancy. Other things that can make the endometrium appear irregular or more echogenic than normal are submucosal fibroids, polyps, and adhesions. So sometimes we can see these when we are just doing a plain transvaginal scan. But if we can't, if you're working for an infertility doctor, or some OB doctors will do this by themselves, it's called a saline infusion sonogram, which we talked about. And they put fluid within the endometrial canal, and it's easier to see fibroids and polyps on the and outlining the endometrial cavity. So it's just a better way of evaluating that before they start infertility treatments. Here is one thing that fibroids tend to have a broad base and a more isocoic to the uterine myometrium. That's the difference between them and a polyp. So here is a submucosal fibroid, and of course this would hurt the implantation process. With a polyp, they seem to have a thinner base here, and they have like a vascular pedicle. So usually when you're evaluating for a polyp, you can see like the blood flowing go into the polyp. Fibroids and polyps can potentially impede implantation, and if found, they can be removed to enhance fertility. So this is the catheter going into the endometrium, pushing the fluid in there, and you can see this band called uterine sneaky eye, probably from like a uterine adhesion that could impede infertility too. Sneaky eye, typically seen on ultrasound as linear strands of tissue extending from one wall of the uterine cavity to the other. And you will see these when a patient is pregnant too. So if you guys remember, we just talked about hydrosalpinx. So yes, a hydrosalpinx could also impede implantation because the little zygote can't travel when there's fluid all in the fallopian tube. Hydrosalpinx is associated with 50% reduction in pregnancy rate, and it doubling of the spontaneous miscarriage rate. So removal of such damaged tubes can dramatically improve IVF success. The tubal patency is assessed by injecting saline into the tube and looking for a spillage of fluid into the cul-de-sac by using contrast to evaluate the spillage. This is called a hysterosalpinogram, and they're very painful, but what they do is they put dye, look under x-ray, and watch the dye go through from the cervix to the endometrium to the fallopian tubes and out through the cul-de-sac. And if you can see that the fluid does go out, it means that the fallopian tube is patent. So because of the expense of contrast imaging, which it is expensive, most centers prefer to start with saline injection to evaluate tube patency. If it's indeterminate, they might try the contrast. So the sonographers, when I've never done this, but I've heard that a couple people have, when they're looking for spillage of saline or air around the ovary or into the posterior cul-de-sac when they're evaluating with saline. All right, so now we're going to go to the ovaries. Now, of course, they're very important in the fertility process too. During the ovarian follicular phase, which is the first phase, if you guys remember, there are several antral follicles that are less than 5 millimeters. You might be asked to do an antral follicle count. So I don't want you to not know what that is. So I want to talk to you a little bit about that. Usually on day 3, some infertility centers and OBs will want to do an antral follicle count to see how many little follicles are on the ovaries. And that can really determine how well the fertility treatments will go. So what you do is you count the little antral follicles, which are these, all of them less than 10 millimeters. So let's count these: 1, 2, 3, 4, 5, 6. So you go to both ovaries and you count these little follicles, and then you write that in your report. Then that will kind of help determine the doctors to know how much medicine they need to give and how well they can expect for the fertility treatments to work and the ovaries to respond. So the follicle selected to develop into the dominant follicle is in response to the FSH. Now, if you remember, they all kind of start out like that, and then one of them decides it's my time to shine, and it gets bigger and bigger and bigger, and the other ones just kind of stay the same. So the dominant follicle will grow at about a 1 to 3 millimeter a day until it reaches the average diameter of 22 millimeters. So if you're doing fertility treatments and you see a dominant follicle, so you see like a follicular follicle, you hate to call it a cyst because it's honestly just a follicle, about 2.2 centimeters, but there's no other dominant follicles, then you know that patient is about to ovulate. And there's what it looks like. Once reaching about the 22 millimeters, that dominant follicle will rupture, and the rupture may be associated with increase or decrease in size. And if you remember, this turns into a corpus luteum or a corpus luteal cyst. Now, the condition that can inhibit release of the FSH and LH is called the polycystic ovarian syndrome, PCOS. So PCOS often occurs with diagnostic triad of these 3 things: oligoovulation, so the patient's not ovulating correctly; hyperandrogenism, they have extra androgen; and polycystic ovaries. So with PCOS, follicles begin to grow but do not develop normally. So in this syndrome, you have a lot of immature follicles that continue to produce estrogen and androgen, but nothing really reaches its peak. So this production inhibits the pituitary gland's function and prevents normal ovulation. And this is due to the pituitary gland producing more LH, luteinizing hormone, than the follicular stimulating hormone, which causes the follicles to remain in an arrested state of development. So no mature ova is released. Fortunately, there's a lot of things they can do if you have PCOS. Clomid seems to really help a lot of the polycystic ovarian syndrome patients by stimulating those follicles to grow. As they grow, they produce more estrogen, and seems to a lot of the patients can seem to ovulate. If it doesn't work, then they can go to fertility treatments. And most of these PCOS patients, they do really well. Women with PCOS may often present with irregular bleeding and thickened endometrium as a chronic elevation of estrogen. So because of the chronic elevation of androgens, many women have extra hair, like around their face, just hair growth that is not normal for a woman. So with PCOS, though, one of the other things is sometimes if a patient cannot get pregnant with that thickened endometrium just having the chronic elevation of estrogen, they have a higher chance of endometrial carcinoma. So that's just something to kind of be aware of. So the Sano findings for PCOS are the round ovaries with multiple small immature follicles on the periphery, follicles 2 to 9 millimeters, and it's been described as string of pearl sign. This is what they look like. So all of these little follicles on the periphery. Now, not all these symptoms happen with polycystic ovarian patients. So it just kind of depends on the severity of the disease. Okay, peritoneal factors. So they may be a cause for as many as 25% of the infertility cases. Peritoneal factors are adhesions and endometriosis. Now, endometriosis is notorious for being a infertility factor because of the adhesions and scar tissue. Adhesions are bands of scar tissue that can cause obstruct fimbriated end of the fallopian tube, causing the patient to not be able to, when they ovulate, the little egg can't get into the fallopian tube and meet up with the sperm. Sometimes fluid will collect in between adhesions, resulting in a peritoneal inclusion cyst, which we talked about. So let's talk about some treatment options. Ovarian induction therapy refers to treatment in which ovarian stimulation achieved in a controlled setting. So what you'll go to an infertility place. Let's say you get to work for an infertility place. I mean, a lot of these huge infertility places need sonographers. So you would, at first, obtain a baseline transvaginal of the ovaries to rule out an ovarian cyst and assess for a presence of dominant follicle. If a cyst measuring greater than 15 millimeters is detected, it could represent persistent follicular activity that could interfere with response to the ovarian stimulation medication. So they will want to make sure that there's no cyst. Some patients, which we laughed because I had to go through this before, the doctors put you on birth control to kind of calm down your ovaries before they start treatment. So as I was going for infertility treatment, I was on birth control for about a month, which I thought it was just crazy odd. But the reason why is because they don't want any cysts to form that could potentially interfere with the treatment. So they want to quiet down your ovaries. Oh, and this is what it says. If serum estradiol elevated and large ovarian cysts present, oral contraceptives may be indicated to suppress follicular activity. And this is the optimal time to assess for intracavitary masses since the lining of the uterus is usually at its thinnest during this time. So what they'll do once they got you under control and you have a thin like a thin little endometrium, they'll start with Clomid. If Clomid doesn't work, then they're going to do injectables. And there's multiple different kind of injectables that are supposed to stimulate ovaries. Then they'll start watching under ultrasound to see how they're doing. Now they want to monitor the number and size of follicles because they are very, very concerned about multiple pregnancies. And they don't want to just like push those ovaries to the limit and have about like 6 or 7 prime follicles that are all going to rupture. And then let's say they all meet up with the sperm and they all go into the endometrium and they all implant. And the next thing you know, you're having sextuplets, which has happened before. If you guys remember, if you look at it, doesn't happen as much anymore. But for a while, they didn't control it as much as they do now. And so you would have a lot of multiple pregnancies. Now they're a lot more concerned, or they just don't reserved about doing that. So if you have more than 3 follicles, you're probably going to have to not go that cycle. So it's a very fine line of enough to stimulate the ovaries, but not too much. So the sonographer needs to count and measure all the follicles greater than 1 centimeter in long and transverse planes. The optimal mean measurement of mature follicles is between 16 to 20. And during this time, ultrasound can be correlated with serum estradiol levels if follicular growth corresponds adequate with E2 production. So they kind of just look through all of the labs together. These are some mature follicles. The correct measurement of the follicle is important because HCG is a substitute for LH and may be given intramuscularly to trigger ovulation. So when it came to me, what they ended up doing was this HCG. And so what you would do is you would, once they gave you the go, you would inject yourself with HCG in your stomach, which was awesome. I loved putting a shot straight in my abdomen. It was terrifying, and it took a lot of courage, but it helps to trigger ovulation. So while they were looking at your ovaries, they're also monitoring your endometrium. And if you think about all this stuff happens, and we don't even know, but when you're going through infertility, you're just at a heightened state because you're in the infertility treatment center so much, and they're like constantly like, well, your endometrium needs to grow a little bit. Oh, you need your follicles to grow a little bit. I'm like, how does this actually happen naturally? Because the endometrium has to respond exactly, and your ovaries have to respond exactly, and it has to be a perfect storm, and then it just happens. But we're all here, which is crazy that our bodies just know how to do this, but it was amazing to me. So they want to monitor the endometrium to assess thickness, echogenicity pattern of the endometrial cavity. And the normal endometrial response associated with ovarian stimulation is increasing 2 to 3 millimeters to get to 12 to 14 millimeters. They really liked at least 10 millimeters by the time you ovulated. That's going to give a plump little endometrium to the embryo. So you measure the endometrial thickness in transvaginal in a sagittal plane, like we've talked about, and you measure anterior to posterior in the endometrial interface. That's what you measure. We know how to do that, right? So there's a couple different ways that you can do fertility treatments, and one of them is called an intrauterine insemination. And that's kind of what this is talking about back here with ovarian induction therapy. So let's say, or timed intercourse. So it's the woman is having trouble ovulating. They do what we've kind of talked about a little bit. They start the HCG. That helps ovulation. Then they do timed intercourse. If that doesn't work, then they might go to intrauterine insemination, where they clean the sperm and they inject it into the uterus to give the sperm a more fighting chance at the time of ovulation. That's the second step. If that doesn't work, they go to in vitro fertilization and embryo transfer. So the IVF is a method of fertilizing human oocyte outside the body. And mature oocytes collected and mixed in dish with sample of sperm. The resulting embryos then placed back into the uterus. And the treatment plan for IVF consists of ovarian monitoring, needle aspiration of oocytes, incubation of oocytes, fertilization, transferring embryos in uterus. And I also had to go through this. So once my ovaries were nice and plump, and they don't care how, they're a lot more liberal with getting as many eggs as you can when they're going to basically harvest them. So what they would do is, like, you're about to ovulate, you take your HCG to help ovulation, then you go into surgery, and they collect as many eggs as they can from your follicles. Then they mix it with the sperm, and then they see how many connect. Then they watch them for 5 days. And you would start, after all this is happening, you would get all of these different emails from the infertility place saying you have 7 embryos that are still alive. You have 5 that are still alive. You have 3. It was terrible. It was so scary. You're like, oh my gosh, are any of them going to make it? And so then at day 5, they put them back in the uterus, and then you have to wait 2 weeks until you take a pregnancy test. It really is terrifying. So the oocyte retrieval accomplished through transvaginal ultrasound guidance while the patient is under anesthesia. And we kind of talked about intrauterine insemination, but it's the technique used to treat male factor infertility. So if the sperm, you don't have as high a sperm count, if they just aren't doing as well as they should, this just gives them a better fighting chance. So the sperm is placed into the uterine fundus. And this might also occur if you need a sperm donor. It's referred to artificial insemination. So there's some complications that are associated with assisted reproductive technology. One of them is ovarian hyperstimulation syndrome, where they've hyperstimulated your ovaries too much. You ovulate, and there's a fluid imbalance, and a patient can get pretty sick from those. Sometimes they have to go in the hospital. One of the other complications is multiple gestations and ectopic pregnancy. OHSS is a syndrome that presents with sonographically as enlarged ovaries with multiple cysts, abdominal ascites, and pleural effusion, and often seen in patients who have undergone ovulation induction after administration of FSH hormone, GnRH analog followed by HCG. More severe cases can cause leg edema, ascites, pleural effusion, hypotension, polycythemia. And sonographic findings in severe OHSS cases will demonstrate enlarged ovaries, multiple cysts, ascites, and pleural effusions. Look at that ovary. Wouldn't you think that would hurt? Oh my goodness. So they have to be liberal but cautious with as many follicles that are going to ovulate, because this could happen. They also want you to watch your weight after you do go through the ovulation induction process, because if you gain too much within that time, like 10 to 20 pounds, that could be a sign of OHSS because of the increased fluid. So patients who undergo IVF are at increased risk for multiple gestations. Estimated about 30% of IVF pregnancies result in this. They're very cautious now about putting more than one embryo in when they do the embryo transfer during IVF, because they don't want you to have multiple gestations, if they can help it. So concern with multiple gestations is if are 3 or more, it's increased risk of fetal or neonatal morbidity and mortality. So they're just trying to make sure that everyone stays safe. Patients who also undergo assisted reproductive technologies are at an increased risk for ectopic pregnancy, which we've talked about too. Ectopic a little bit. We will talk about it more in a couple of chapters. Ectopic pregnancy is a pregnancy implanted outside the uterus. And a very rare complication is a heterotopic pregnancy, where you have an intrauterine pregnancy and then you have also an ectopic pregnancy that is coexisting. This is a uterus here, and there's 2 babies. So this is an intrauterine twin pregnancy that's probably happened from IVF or intrauterine insemination. This is a live heterotopic pregnancy in a patient shown with in preceding slide. So that's inside the uterus, and this is ectopic pregnancy that was also with that. So that's kind of a sad deal. And that's it, guys. All right, we'll see you next time. Bye.